My name is my name is Meenu Anand. I serve as the Director of Global Cancer Prevention and Screening at the American Cancer Society and the co-chair of Cervical Cancer Action for Elimination, or CCAE, along with colleagues from Cancer Research UK. Some of you might be familiar with CCAE as a global network with a long history in supporting individuals and organizations working within cervical cancer advocacy. Now, as a collaborative initiative led by the American Cancer Society and Cancer Research UK, CCAE continues its legacy as a sharer, supporter, and amplifier, bringing together organizations and experts in the global community to exchange expertise and resources, and providing a platform for all voices to be heard in critical conversations. Next slide, please. Before I hand over to our moderator for today's dialogue, let's go over some important housekeeping items. If you need translation, click the Show Captions button. Captions will appear above the control toolbar. By default, English is set as the speaking language the captions are generated in. If you're having any technical issues throughout today's dialogue, please use the chat box to let us know and someone will help you. Please note that today's dialogue is being recorded. Everyone who registered for the session will receive a follow-up email with the recording, slides, and any links shared by the presenters today. Next slide, please. Today's session is one in a series of dialogues with experts in new and emerging topics related to advancing cervical cancer elimination. We received a lot of questions about HPV vaccination. Please take a note of the links in the chat. These are from previous CCAE dialogues that covered the topic of HPV vaccination. Next slide, please. If you are a civil society organization interested in taking action to increase the uptake of HPV vaccination in your country and communities, please read more about the upcoming virtual learning series hosted by CCAE. Applications are due by the end of day today, July 15th. Next slide, please. I would now like to introduce my colleague and friend, Ms. Mridu Gupta, who will be moderating today's session and facilitating the panel discussion with our esteemed presenters. Mridu is the Chief Executive Officer of Cancer Awareness, Prevention, and Early Detection Trust, in short, CAPID Trust or CAPID. CAPID is a community outreach organization in India working in the healthcare domain since its inception in 2014. CAPID's core area of work is cancer prevention and early detection with a focus on cervical cancer. With further ado, the floor is yours, Mridu. Please take it away.
Thank you, Meenu. Thank you for the introduction. It is my honor to moderate today's session with our excellent group of presenters on novel approaches to cervical cancer screening in low-resource settings. So good morning, everybody, or afternoon or evening, depending on where you are. We have over 50 countries that have registered for this event. So I'm sure all of you are in different times of the day. Thank you for being here. During today's session, we will have 6 presentations, followed by a question and answer panel with the presenters. During the registration, we had questions that were submitted, and I will be reading out those questions for the panel to answer. But we are happy to take your questions live. Throughout the presentations, if you have any questions, please add them to the Q&A box that you can see on your screen. They will be answered either through chat or live during the panel discussion. If you have a question for a particular presenter, please tag the person by name, and we'll see that they can answer your question. So let's get started. We will start with Dr. Silvia de San Jose. Introduction to PAVE protocol is what she's going to talk to us about. Dr. de San Jose is an epidemiologist who has been involved in research on human papilloma virus and its association with cervical cancer for over 35 years. She has made significant contributions to understanding the role of HPV and how this knowledge can be applied to primary and secondary prevention efforts to reduce the burden of cervical cancer. She has served as president of the International Papillomavirus Society and currently co-leads the Human Papillomavirus and Automated Visual Evaluation PAVE consortium. Dr. Sylvia de Hassan Jose, over to you.
Thank you very much, Mrs. Rupka. It is a real pleasure to be here with all of you, and I hope, let me make sure that I have that, yeah, that it's now, okay. So, yes, my name is Silvia de San Jose. I work as a co-PI of the PAVE project, and I work in Barcelona at IS Global, but nowadays we all work internationally. So the location is not the key aspect nowadays. It is a pleasure to be here. I have a short presentation to introduce you what we mean by the PAVE study, PAVE protocol, PAVE consortium. It all refers to human papillomavirus and automatic visual evaluation. And we will try to explain what all these things mean. And I would just like to emphasize that cervical cancer is preventable. Cervical cancer mortality can be significantly reduced. And we are now in a moment that we believe that public awareness is steadily increasing. And this is an important observation because like 20 years ago, we were traveling around the world, and cervical cancer was really never mentioned in many of the political tables. Now we are not seeing that. We are seeing a much stronger interest in trying to do something about this disease that kills so many women around the world. So in this session, we want to introduce the project PAVE. PAVE is grounded in the most advanced scientific knowledge on HPV and on cervical cancer prevention. The project is especially suited for low resource settings and for the underserved populations. As a global aim, we want to be a transformative, efficient, and cost-effective solution. And we will show you that with PAVE, we are using HPV testing with detailed information using the HPV type information. That type means that the types that are related to carcinogenesis will be explained much more in detail by Federica Inturrisi. This allows us to use self-sampling, so women are not self-screening, are self-sampling their cells to be handed over to the laboratory. And all this information then is contrasted with an AI solution. More in detail, this PAVE project has now gathered information from over 50,000 women in 9 countries. You can see here the stars of the countries, and the University of Colorado is the headquarters for the AI solutions. And the project means that we call women to participate in the screening process. Then we ask them to self-sample cells from their vagina. We explain how to do that. Then this sample is taken to the laboratory, and if the laboratory tells us that the woman is positive, then we ask this woman to go for an extra visit, a triage visit. If the test is negative, we tell the women that they are negative, that their risk of having a disease in the next 5 years is extremely, extremely low, so that they can be relieved. Those women that they are HPV positive, then they are sent to a gynecological examination. We use a mobile colposcope that allows us to take images of that cervix so that we can see, we can do what generally they do, VIA or colposcopy impression, whether there is a lesion or not, but we take the images. These images will then be taken to our lab at this moment. And in this lab, we will run an AI algorithm. And this algorithm together with the information on the HPV type, we will be able to assess the risk of that woman. All this has been trained using histological verification, which is now, this is a validation study. Okay, so all the women that were positive will have had a biopsy taken so that we can contrast what our score system is telling us in terms of risk of that woman to have a precancerous lesion that can be managed or a cancer. And then we can contrast with what the laboratory in pathology is telling us. So the purpose is that women are being classified in 3 categories of 4 categories: high to highest cancer risk in red, a medium cancer risk that is depends on our ability to follow up these women. We can do treatment or we can just follow them up. And then the low cancer risk, which will tell women that their risk is as low as almost as being an HPV negative woman. So more or less this green group will be like 1/3 of those women that they go that they have an HPV test. So if we are deciding to treat the red and the yellow, then we have a thermal ablation that can be applied at the moment we see that woman. And if the lesion is big enough, then we can refer that woman for a an hysterectomy in the case of a cancer case. So we have been doing that in all these 9 countries. Now we have completed this first phase. And this first phase, we are now writing the papers. We have a preliminary publication, Befano et al. In 2025 and Journal of National Cancer Institute. We are now in a phase that we call it PAVE 1.5, which is we are using this algorithm, the AI algorithm, the reading of the images. We are going to use it in the clinics. So until now it was done at Colorado, and now it will be done at the site so that the user, the provider can check how it works and how comfortable they feel, and just to detect if there is any issue of usability. So this is going on. It should be finished by the end of this year. And then we are engaged now in the PAVE 2.0, which is going to show the full usefulness and effectiveness of this program in the field. So we then will perform this PAVE 2.0 with the idea that after we validate the effectiveness of the whole program, this can be given to implementers to be outscaled. So we think that, believe that we are really transforming the screening. We think we are efficient and we are working on the cost effectiveness. We think it's likely to be cost effective. We can work as well on scenarios that they are single day to screen. So we screen, we assess and treat during the same visit, which is a very important issue in some parts of the world. We believe, and we have now proven in 9 countries, that this is an easy screening. It has minimal discomfort with the treatment. Women are tolerating very well the thermal ablation. And very importantly, the whole introduction of this screening is a low cost with a very advanced technology. So this is the picture, just to finish my introduction, of some of the PAVE consortium researchers. We are over 100 people. We have been working over 10 countries. We have many public institutions and universities, and as well we have a liaison with the private sector to bring the devices at the best way to be performant, and that should try to stay at a very low cost, so that everybody can access to this new technology. With this, I finish my introduction and happy to respond to any question.
Thank you, Dr. de San Jose. That picture was just so heartening, such a happy picture that you ended on. And I can see the benefits of this for countries like ours, definitely. And I so relate to your fact that now people are talking about cervical cancer. When we started in 2014, nobody was talking about cervical cancer. We had to educate policymakers and we had to educate donors that, we need funding to work on this. Nobody. But now it's really heartening, especially after WHO's call to action in 2020. There's been a lot of movement and momentum around cervical cancer. Thank you for this. Thank you. And now we will move on to Dr. Federica Inturisi. Dr. Inturisi will speak about the novel self-sampled HPV test with genotyping. Dr. Inturisi is an epidemiologist with the MSF Foundation, Doctors Without Borders. Within the PAVE consortium, she chairs the HPV working group and serves as the regional referent for East and Southern Africa, supporting particularly Tanzania, Malawi, and Eswatini. Her work has focused on the self-sampled HPV screening component, including assay validation, optimizing workflows, supporting HPV laboratories in the field, and ensuring high-quality results. Over to you, Dr. Inturisi.
Thank you. Thank you so much. So good morning, good afternoon, wherever you are. My name is Federica Inturisi, and my talk will focus on the self-sampling and HPV genotyping as part of this PAVE novel strategy that we are talking about today. And the objective of PAVE overall is really to have a screen triage treat strategy that is simple and allows for identification of women at increased risk needing treatment. Here are the details of how we are doing it in the meantime. And as you have just heard from Dr. De San Jose before this talk, women are asked to collect a vaginal self sample, and this undergoes HPV testing using a test that provides extended genotyping information. HPV negative women are reassured, and the positive are invited for a gynecological visit. And I will really focus on this first part of the strategy, while my colleagues at the later talks will go into details of the triage step. Let's start with self-sampling, which is preferred by women and providers and has the great benefit of increasing coverage while saving resources. And this is because with clinician-collected HPV testing or other tests, all women attending screening would require a speculum examination. But when self-sampling is used and women collect a vaginal sample by themselves, the vast majority of women being negative can be reassured, and only the positive ones will require a speculum examination for management, either being triage or treatment. And I saw in the chat a question, and this is the answer. In the PAVE consortium, self-sampling is used as primary screening so all women are offered self-sampling using different strategies depending on the settings. Here is just some real-life examples. In most settings, self-sampling is offered at the clinic, both among women going for screening or attending HIV clinics. In Nigeria, there is a door-to-door strategy. It's also offered at work, and this is an example from garment factories in Cambodia, and a series of community strategies. And these are just some examples. For example, large events with a health focus have been an opportunity to engage both women and providers, but also organized outreach campaigns, especially for rural areas, like the ones organized by the Brazilian team in the Amazon region. And a self-sample is then tested for HPV DNA. And before we go into details of the HPV test, we take a step back to understand the HPV genotype contribution to cervical cancer. This is a recent summary of the large body of evidence on the type contribution to invasive cancer. And the graph virtually represents 100% of all invasive cervical cancer cases, as indicated here at the bottom. Let's start from the top, where we can see the type contributing the most. HPV 16 alone has the largest contribution of almost 62% of the cases, followed by 18 and 45, which have an important role, particularly among adenocarcinomas, and it's importantly seen in cancer cases, and much less in pre-cancer cases. Then come other alpha-9 types that are related to 16 are depicted here in green. And then the other higher risk types that are here depicted in blue. If we focus on the first 13 types, this all contributes to 99.2% of all invasive cervical cancer cases. And when focusing on this natural history of HPV and cervical cancer, we can see the importance of designing or having HPV tests that are able to reflect this natural organization of genotypes into risk categories. Such tests should also be very sensitive to permit cell sampling. We have seen why for the benefits. And because of this high sensitivity, it should also be able to address contamination, but also simple and affordable to allow for accurate testing in simple lab settings. So particularly for the PAVE study, isothermal amplification test called ScreenFire, providing extended genotyping, was redesigned before the PAVE study started. This assay has genotyping organized in 4 type groups that are ordered by cancer risk, exactly as we have seen before. So HPV 16 is given priority as the first channel, 18 and 45 the second, the alpha 9 groups, the alpha 9 types in the third channel, and then a fourth channel with the low risk types. And hierarchical means that in case of positivity for multiple channel, then those are interpreted in order, meaning that a woman should be managed according to the channel that carries the highest risk. For example, if a sample is positive for the first and the third channel, then it's important that that woman should be managed according to the risk carried by HPV 16, the first channel, as the highest one. And ScreenFire HPV assay is able to run on tabletop equipment. It's based on an isothermal amplification and a 3-nucleotide technology that limits the formation of primer dimers, allowing for a very sensitive type-specific amplification. The primers favor detection of 16 and then detection of channel in the risk-based order that we have just discussed. And when coupled with cell sampling, once the dry self swab has been lysed, then it is only one pipetting step is needed to transfer the sample into a pre-packed assay version, which is depicted here, which is called Zebra Biodome. And this includes pre-aliquoted reagents that reduce assay preparation time, allowing for same-day strategies. And it also contains anti-contamination gel matrix that reduces the risk of leaking out amplified materials, so reducing risk of contamination. The reagents have a cost of approximately $6 US per test, and the assay has been extensively validated. I'm now going to show some preliminary results that we are in the process of updating since the study phase is now completed with over 50,000 women that have been screened across the 9 countries part of the PAVE consortium. The table that you will look at are focusing on the yield of CN3+ separately by HIV status. And I just want to ask you to take this for the concept. The numbers are still small and we are updating them. My table specifically will focus on the HPV genotype risk stratification, and you will see in the next presentation the complete tables. So what the PAVE results show is that in a given population, if we have information on the HIV status, then the CN3 plus yield among HIV negative or unknown is 4%, and among women living with HIV is much higher. But if we didn't have any information on the HPV channels, so if we only knew those who were HPV positive, then all HPV positive women would be managed the same way according to this disease yield. But we do know what the HPV type channel is because this is an information that comes with the primary HPV result. So if the extended genotyping test is used, this information in the type grouping comes with the primary test. And here we can see that the CN3+ yield goes from 1.9 for the fourth channel to 13% for the highest risk channel, the first channel 16. For the purpose of this analysis, the second and the third channel have been combined as their CN3+ yields were similar. And this is a clear risk stratification going from the lowest risk to the highest when using extended genotyping. And this risk stratification is even more pronounced among women living with HIV. Even as I said, the number are small and they will be updated in our final analysis. This information can be used to manage women accordingly. To conclude, HPV testing is recommended as primary strategies across all settings for prevention of cervical cancer. Self-sampling is preferred both by women and providers and represents a key opportunity to increase coverage, particularly when looking at low-resource settings. HPV genotype is strongly linked with the risk of invasive cervical cancer, and it adds information to improve management. So we can have a risk stratification based on extended genotyping that can be obtained at no increased cost. And with that, I would like to acknowledge all my colleagues and thank you for your attention.
Thank you, Dr. Inturisi. That picture again. Such a happy, positive picture. And thank you for the information. Extended genotyping is a conversation that's happening even in low and medium income countries. And there's always this debate about whether it's needed or not. So thank you for that. It really helps understand this better.
Thank you.
And we will move now to Mr. Brian Befano. Mr. Befano is going to speak about the AI methods. And Mr. Befano is also a clinical epidemiologist and PhD candidate at the University of Washington, whose work centers on human papillomavirus epidemiology and control in diverse global settings. Leveraging a BS in mathematics and an MPH in public health practice, he partners with the US National Cancer Institute to quantify HP prevalence, map genotype distribution, and elucidate how HIV co-infection accelerates cervical carcinogenesis. His portfolio spans large cohort analysis, implementation studies of HPV screening algorithms, and assessments of vaccine impact in low-resource environments. Currently, Befano studies cervical cancer etiology, refines screening strategies for women living with HIV and those in lower and middle-income countries, and serves as a key contributor to the multi-country PAVE HPV-AVE initiative. Over to you, Mr. Befano.
Thank you for the introduction, and I appreciate my prior colleagues introducing the study and talking a little bit about HPV results. I'm going to not show too many results. This is more just to provide some background on the AI approach that we've been taking in PAVE. So I'll motivate that a little bit with why we think a triage step is important. Go over a little bit of the history of how we've gotten to where we are, and then talk about the model development work that we've done and get you all the way up to the model that we're currently using in PAVE. So why triage? So as Federica just showed, genotyping is the extended genotyping assay that we've developed. Stratifies risk in both HIV-infected women and women not living with HIV. And it does a really good job of stratifying the highest and lowest groups for around half of the population. But around half of the population that fall into that middle HPV group have very similar pre-test and post-test risks. So about 4.1% of the overall high-risk HPV positive have CIN3+, and that middle group moves to 4.6%. And then among women living with HIV, it's 26% pre-test versus 32% post-test. So for those groups in particular, we really like to be able to further stratify their risk and really separate out those at highest risk from those at lowest risk. And then even for the highest risk HPV-16 channel as well as the lowest risk channel, we would like to get further stratification there to really identify among the 16 who is at the highest risk of having disease. And in the lowest HPV group, who is at the absolute lowest risk. And that would further allow communities and the medical community to prioritize follow-up and prioritize resources on the people that are really at highest risk. And so that brings us to the triage test that we're using here, which we believe can be an AI-assisted visual inspection. So the little bit of the history, the earliest work that we did on AI, which was published in 2018. Now, when we look back, we realize had some problems, and it really suffered from two main problems. The first was the model that we were using was a binary classifier. It separated images into, essentially normal versus precancer plus. And we believe that model was not optimal for this task. And the second issue that we ran into was we believe that the experimental design for that study probably led to overly optimistic results. So on the model choice side, on the left here, we're seeing the results of two images from the same patient, and we're looking at the resultant scores mapped against each other. And this model tends to push people away from, this middle area, which would be kind of an unknown area, into each of the corners. And so when it does that, we get these two corners on the off axis, where the algorithm is fairly confidently wrong. So in one case, it calls it a precancer, and in another case, it calls it a normal. This is not a pattern that we really want to see on this test repeatability. We'd much prefer, if the algorithm is unsure of what it's doing, for it to say, put it in the middle and call it unsure. And that really motivated the follow-up work that we've done here. On the right-hand side, this is the AUC or ROC scores from the original work. On the left is the AVE model, and on the right is the human red cervigram results. So on the left, that AUC is 0.91 for the AVE, and on the right is an AUC of 0.69 for the human red cervigrams. So in comparison to the cervigrams, the AVE is significantly better, and it's better in a way that probably is not realistic. This study design took our entire set of cervigrams and trained on around 90% of the data and used about 10% of the data as the test set. And that led to the algorithm, overfitting or learning a little bit too much about the data and generating predictions that were, we don't think are realistic. So these design issues led us to kind of reassess the approach that we've taken. And so in a large ablative study, we pulled together multiple different data sets. So in this case, we have 5 different data sets using multiple different types of cameras coming from multiple different types of patients. We pulled them all together and we created a training set and then 2 test sets. And here I think our training set was somewhere in the order of 60% of our data. So our training set is still large relative to the overall data set, but we have 2 test sets that are also large, approximately 40% of our data. And by splitting it into 2 test sets, we were really hoping to be able to say, when we evaluate model performance in test set 1, we're going to select the best model, and then we're going to use the second set to confirm that those findings are still valid. And then I think the most important part was the AI models that we use have a lot of different options that we could, potentially implement. Different architectures, different loss functions, different balancing strategies, different dropouts, and critically different amounts of ground truth levels. And so we did a huge combination of all of these and then evaluated which ones were performing best. The main design choice that is critical, I think, for the AI approach that we've decided to take is to split or move away from that binary approach that we used in the first evaluations and move to a 3-class classification. And we believe this more closely follows the underlying disease state, where you have patients that are HPV positive and have quite severe disease, and so we classify them as severe plus. And we have a lot of people who are, fairly normal. So either HPV negative, or in these cases as a triage test, people that are HPV positive, but the cervix is fairly normal looking. And we classify them into a normal category visually. And then we have a large middle category that's indeterminate, that's in between, that we don't really know if it's high grade or if it's not high grade, or maybe the visual picture isn't quite clear on what we're seeing. And so this newly redesigned model uses that middle category to push people that the model is uncertain of into that category, as opposed to the prior model, which kind of randomly pushed them into either precancer or and so these new models that we use still generated ROC curves that showed good risk stratification, but not on the order of 0.91, which we saw before. And on the bottom right here, we're looking at a Bland-Altman plot, which is essentially showing the variability between two images from the same patient. And again, here we see, not a lot of variability. And then in this middle class, which represents that indeterminate class, also not a lot of variability. So that behavior of pushing things into the misclassified axis goes away with this approach. The last issue that we had is one of, again, portability versus overfitment. In that original JNCI effort, we trained on 90% of our data, and so we overfit to the remaining 10%. And we wanted to obviously avoid that in this situation. So we have the 5 studies that we used for the model selection. That's the basis for what we train our models on. But we want to be able to use that model in PAVE. And so we did this study of essentially saying, how much PAVE data do we need to include in our training from those 5 studies in order for the algorithm to be able to read Liger images and accurately diagnose from those images. And so that's what this graph here is showing, is that if we add no patients into the data set, the y-axis is accuracy, we get quite low accuracy. And then we incrementally added PAVE patients, and we see that the accuracy goes up. And at some point starts to kind of tail off, which is an indication that there are gains to be made by adding more patients, but most of the accuracy is already there. So for the results that my colleagues are going to show later, we took 40 patients from each of the 3 ground truths, so a total of 120 patients from PAVE, and we included them in the large training set that we have. So again, instead of training on 90% of our PAVE data, we're training on somewhere in the order of 1 to 2% of our data. And so we're avoiding overfitting, but we're also getting this model portability. And so this is what we kind of see in terms of the PAVE images from the most preliminary data. On the right-hand side is an ROC curve. In blue is the HPV result, and it's broken up into the 4 HPV categories. The dotted red line is the AVE in 3 levels, and then the dotted green line is the HPV plus AVE. So the things to note here, again, this is among HPV positives. So the AUCs on these are a little bit lower because this population is a little bit harder to stratify. HPV and AVE both generate similar risk stratifications. The AUCs are 0.72 and 0.74 for them respectively. And then importantly, when you combine HPV and AVE, you get additional risk stratification. So that green line is above and to the left of either the HPV or the AVE lines alone, which is great. We were a little bit concerned at the very earliest stages that maybe the HPV test and the AVE test were both generating risk stratification, but were reading the same thing. Maybe they were collinear. And it turns out that they're not. They are assessing different parts of the underlying risk. And when you combine them together, they're generating additional risk stratification. That's the end of my presentation, and I'll turn it over to my next colleague.
Thank you, Mr. Befano. That is so interesting, especially because it's completely new to me. So it's all aha moments. And that was really interesting. I'm sure the others found it too. We will move now to Dr. Didier Megeman, who will talk to us about how to create risk-based guidelines with HPV and AI-based visual evaluation tests. Dr. Eggman is a biostatistician and cancer researcher with experience in epidemiology and artificial intelligence. Her work focuses on HPV and cervical cancer with research interests in developing and validating AI-based visual biomarkers and obtaining risk-based screening guidelines. She aims to improve early detection through clinically meaningful and reliable biomarkers. Dr. Eggman.
Thank you so much for this nice introduction. And actually, my colleagues already set the stage for the PAVE strategy, extended HPV extended genotyping and AI-assisted visual evaluation. So in my talk, I will be talking about how we can develop risk-based screening based on this strategy. But before going into details, I want to briefly talk about what is risk-based approach in management. So it is not quite different than what the clinicians implement during their daily practice. So what they do is clinicians collect some inputs, which are markers. These can be age of the patient, that also relates to SCJ visibility. And they can collect HPV either positive, negative, or genotype information, or they can collect visual impression, VIA, cytology. So these are all inputs. And then with these inputs, they intuitively assess the risk of their patient to create a suitable management. And these management options can be as simple as, should I screen this patient or not screen? Should I treat or not treat? Should I treat or should I follow up? Or they can be as extensive as we have in the US. But with the risk-based approach, what we do is by using these input markers, we obtain absolute risk of the individuals so that we can determine objective management options for everyone in a specified setting. And we also need to assess the portability of these risk estimates. So as my colleague, Mr. Befano mentioned, like we have been testing the portability of the AI test and also the HPV extended genotyping test. So first, I would like to briefly mention how we developed risk-based guidelines in the US setting. So in the US, we developed the first risk-based screening guidelines in 2019. And for that, as I mentioned, we obtained the absolute risk of every possible screening test result. And then based on some benefit harm calculations, we worked with a group of expert clinicians to define the management thresholds that they feel safest for their patients. So in the US, but for the risk, we use the CIN 3+ risk, because in screening, we want to focus on a robust measure that the robust precancer measure that will most likely progress into cancer. And that's why we are calculating the absolute risk of CIN 3 or worse situation. So in the US, if the current CIN 3+ risk is 4% or higher, the management options can be either directly going to colposcopy, or they can skip the colposcopy and implement expedited treatment based on where their risk falls in among these management thresholds. Or if their current risk is less than 4%, we look at their long-term risk to define the safest time interval to rescreen these individuals. So for creating a risk-based guidelines, essentially what we need is obtaining the absolute risks of the screening test results, and we need to set some thresholds for available management options. So with this in mind, how can we create risk-based guidelines with the PAVE screening strategy? So as my colleagues mentioned, our strategy starts with HPV self-sampling. If they are HPV negative, they are reassured. But for the positive individuals, we know their extended genotyping information, and we get this information in hierarchical levels of 4 channels. This is the decreasing severity order, and then all of the HPV positive individuals, they go through a vaginal examination, and our AI-assisted visual evaluation tool determines, based on their image, one of these 3 categories, either normal, or indeterminate, or severe, as my colleague, Mr. Bufana, mentioned in his talk. So what we try to do with these 2 biomarkers, HPV extended genotyping and AI-assisted visual evaluation, we try to create the risk profile of the population in these settings. So, and we assume HPV 16 positive with a severe looking cervix will have the highest risk, and then we will have high groups, medium, and low. So with the real data, I want to demonstrate this risk profile. And in our data set, we were able to stratify individuals based on their HIV information. So we grouped them into 2 groups, 2 categories, HIV negative or unknown, or HIV positive. And as my colleague, Dr. Inturisi, mentioned, among the HIV negative or unknown group, among the HPV positive individuals, the CIN3 plus risk is 4.1%, and this risk increases to 26% among the HIV positive and HPV positive individuals. So, and we can obtain a nice risk stratification by only looking at the HPV genotyping groups, as my colleague mentioned. And also, we can obtain some risk stratification with the AI-based tool based on their visual biomarker. So that 4% risk increases to 7%. If their cervix looks clear, the risk stays around the same, 3.2% if they are indeterminate, if they're grouped in indeterminate group, and their risk drops to almost 1% if they look normal. So this is the combined risk profile when we combine these 2 biomarkers, HPV extended genotyping and AI-based visual evaluation. So with that, we can obtain more refined risk stratification. The highest risk increases to 19% for HPV 16 positive with a severe looking cervix. And then we have the other red category the risk ranges between 4.2% to 10%. And then the medium category around 3 to 4%. And the lowest risk category, the green group. And we see a similar pattern in the HIV positive. And I should mention that these results are from our recent paper published in JNCI, and these results are from the pilot study results. So now we have more data and we can obtain more robust results. We will actually publish that data soon, but right now the HIV positive table has very small numbers, but we will publish the more robust results very soon. So that 26% risk, it is stratified with the HPV extended genotyping, the risk increasing to 40% if we know that they are 16 positive, and the risk drops to almost 8% if they are infected with the lowest type groups. And then we also see some risk, a sort of good risk stratification with the only visual biomarker, 26% risk increases to 45% and decreases 45% if we know that their cervix looks severe, and the risk drops to 4% if their cervix looks normal. And this is the combined risk profile when we combine these two biomarkers together. So the highest risk we obtain is 58%, and the lowest risk is around 1 to 2%. So like some categories, as I mentioned before, are very small, but we still combined HPV-16 category with the red because we know that infection with HPV-16 is, very risky. But as I said before, these numbers are very small, but we have more robust results that we will publish soon. So how can we obtain the management thresholds that will help us create the risk-based guidelines? So as I said, first we need to obtain the absolute risks of every screening test result, and then we need the management threshold. So to be able to obtain these treatment or management thresholds, in this example, I will show the option of either treat or not treat management option. And so this is a concentration curve which demonstrates a population, the full screening population on the x-axis cumulatively from 0% to 100%. And these individuals are ranked based on their risk in the previous table. And as you can see, the color of each dot is matching with the risk table. And the y-axis shows the cumulative percent expected precancer cancers in this population. So, for instance, if we and we have two curves, one for HIV positive and one for HIV negative or unknown population. So, for instance, if we look at HIV in the HIV positive population, the first risky type group was HPV-16 positive with a severe looking cervix. So if we only treat this group, we would be treating almost 4% of the population and 4% of the HIV positive population. And in return, we will be treating 19% of the expected precancer cancers in this population. So I will show you some some potential thresholds in this data set. So if we first focus on HIV negative or unknown population, the first potential threshold can be chosen at the end of all of the red risk categories. So what is the implication of choosing this point as a treatment threshold? So that means we need to treat everyone falling into all these four categories, and we would be treating 8.2% of the full screening population, and in return, we will be eliminating 63% of precancer cancer cases. Another potential threshold could be choosing this, the end of the yellow risk group. And the implication of this choice would be treating 18% of the HIV negative unknown population, and in return, treating 90% of precancer cancer cases. So the health decision makers in each setting can decide on these potential management thresholds based on their available treatment options or available like their risk awareness level and available resources in that setting. So, and then if we focus on the HIV positive population, the first potential threshold could be choosing all of the red risk groups, and the implication would be treating 16% of the HIV positive population, and in return, eliminating 73% of the precancer cancer cases expected in this population. And another cut point could be again chosen at the end of all the red and yellow boxes, risk categories, I should say. And the implication would be treating 31% of the HIV positive population, and in return, treating almost 99% of the precancer cancer cases. And as I said before, I should mention that these are some examples, and each setting can define these thresholds based on their available treatment options, screening options, available resources, and their risk awareness level. So in summary, when we conduct screening, it's important to allocate our limited resources for high-risk patients to maximize the utility of screening. And risk-based guidelines will help us determine the high-risk patients who will need and benefit the treatment most. And with the risk-based guidelines, we can provide more objective management decisions across a whole country. So with that, I would like to thank all my colleagues in the PAVE consortium, and thank you so much.
Thank you, Dr. Eggerman. I know we have a lot of questions on creating risk-based guidelines, and we can explore this further during the Q&A. But thank you for that. We will now move to Dr. Rebecca Perkins, who will be talking about translating screening science to practice and policy. And that is something that I'm personally really interested in hearing, Dr. Perkins. Dr. Perkins is a professor of obstetrics and gynecology at Tufts University School of Medicine and Tufts Medical Center. Her career is dedicated to reducing cervical cancer. Her current research focuses on novel approaches to cervical cancer screening and guidelines for screening and management of abnormal test results. She leads the clinical management group for the PAVE consortium. Dr. Perkins?
Thank you. Can you hear me okay?
Yes.
Great. So thank you so much for having us today. We are so happy that all of you are here with us to learn about PAVE. And I will try to summarize everything, and then we'll open it up for questions. Actually, no, and then we'll have Dr. Nicole Campos, and then we'll open it up for questions. So the scientific principles underlying risk-based management are that if we manage according to the risk of precancer, this will allow us to focus our resources and treatment on the people who need it the most and avoid overtreatment and the consequent side effects in people at lower risk. And so this applies in all settings, in limited resource settings, in high resource settings. This is a general principle that will benefit everyone. In PAVE, we need to ensure that our screening method effectively separates low risk from high risk patients. And there's worldwide consensus that this is done with HPV testing because it is the absolutely most sensitive method that we have. It detects more than 90% of precancers at a single screen. And if someone is negative, their risk of developing a precancer or cancer in the next 5 years is somewhere on the order of 1 in 1,000, so extraordinarily low. We know that HPV genotyping is very important for risk stratification, with HPV 16, the most aggressive genotype, being responsible alone for about 50% of cancers, whereas some of the other types that do cause cancer cause less than 1% of cancer. So they're really much less important in the overall cancer burden. And then we know that in a given population, somewhere between 10 and 30% of women will test HPV positive, and we really don't want to treat that many people because treatment does have side effects and it's uncomfortable. So we want to know how to figure out who needs treatment and who does not need treatment. And so automated visual evaluation with artificial intelligence has the goal of improving visual identification of lesions to better determine who will benefit from treatment. So I'm going to go through the basic principles underlying risk-based management, and this will be a little bit of a review and summary from some of what the other wonderful presenters have said. So the principle number 1 is screen using self-sampled HPV testing. HPV testing detects 90% of precancer at each screen. When it's done using self-collection, then you need fewer clinical personnel. You don't need to sterilize your speculums, and it actually, if you have adequate resources, allows for mass screening of a factory or a city or a setting in a very short amount of time. And then you don't have to worry about sterilization problems with the speculum that maybe, used in an HPV positive patient, not sterilized well, used in an HPV negative patient, and then you gave them HPV. We don't want to worry about that. And self-collection is a great way to overcome that problem. The graph on the right shows the extraordinarily low risk of developing precancer or cancer within 5 years of a negative HPV test, and how superior it is to a cervical cytology or pap smear, where the risk is low in year 1, but continues to steadily rise because the sensitivity of cytology is lower, only 70%. And visual inspection with acetic acid has at best the performance of cytology and also varies very much by the provider performing the screening. So it's less ideal. The second principle is that HPV testing requires triage. Between 10 and 30% of women will test HPV positive. That rate is even higher in an HIV positive population. And so treating everybody would result in very high rates of overtreatment. So we need to identify people who will benefit the most, and HPV genotyping is the first step in this strategy. And the nice thing is that the genotyping results are provided by the test. When the test results as positive, it's not just positive, it's positive for 16 or positive for 1845 or positive for the different channels. And that tells you right off the bat who is at higher risk and who is at lower risk. The third principle is that secondary triage options involve visual evaluation of the cervix. So many places are using visual inspection with acetic acid or VIA. And VIA is not bad, but it's highly, highly subjective and highly, highly variable. So you kind of don't really know what you're getting when you say VIA. And the goal of the AI-assisted visual evaluation is to standardize image evaluation to assist clinicians in visual assessment and hopefully to avoid errors in management. So on the lower left, there's VIA. The person is just looking at the cervix and figuring out their impression. On the bottom right, you have AI-assisted visual evaluation where the clinician looks, they take a photo, the photo runs through the algorithm, and then the algorithm gives a result of normal, indeterminate, or severe, which allows the clinician to be assisted in their impression. They may say, oh, why is that severe? Maybe I'll take another look, or they may reinforce their impression. The fourth principle is that HPV genotype and the AI-assisted visual impression together provide superior risk stratification. So you just saw this table in Dr. Egeman's presentation, but essentially I just wanted to reemphasize that when you have the lowest risk genotype channel and a normal AVE impression, there is approximately a 0% chance that that patient has precancer. We never get 0 in anything. This is extraordinarily good and helpful because this was, a total of 117 patients. It's a lot of people that you can say, you know what, you're fine. Go live your long, happy, healthy life. We do not need to do thermal ablation on you right now. Similarly, in the lowest risk channel, when it's an indeterminate AVE prediction, or in the middle channel, where it's a normal AVE prediction, the risks are very low in our HIV negative or unknown population, and they do start to creep up a little bit for that middle channel, even with a normal impression in the HIV positive population, because that population has a substantially higher risk. On the other side of this table, when you have an HPV 16 positive patient with a severe AVE impression, they have almost a 20% risk of having cervical precancer right now in front of you if they are HIV negative, and that risk rises to almost 60% if they're HIV positive. So we see, well, an infinite, but at least a 20 to 50-fold increase in the risk of having precancer when we go from the lowest risk to the highest risk. So we really see tremendous risk stratification, which allows us to figure out who to get in for follow-up first, who to treat, who we can safely not treat extremely well. Treatment is also critical. You will not prevent cancer if you don't treat the precancers. So both excisional and ablative treatments are about 85 to 90% effective for reducing the progression to cancer among women with a high-grade precancerous lesion diagnosed on biopsy. And thermal ablation can be performed on most lesions with low rates of serious complications and typically does not need a physician to perform them. A nurse is able to perform them because the complication rate is lower. Excisional treatment with a LETS or LEAP procedure will still be needed for patients with larger lesions or more difficult lesions, those that don't meet the WHO criteria for ablation. And so there will need to be referral to physicians or physicians on site for patients who require these types of treatments. And they do have, because they have higher rates of bleeding and infection. So they require a higher level of trained personnel to perform them. So this sort of puts it all together, how you can use risk in resource-limited settings. And Dr. DeSanjose asked me to put in this very important note that you need to track your patients. Even if you are having a same-day strategy, you are still going to be screening people in the morning and calling them back in the afternoon. So you need to know whose sample is whose. And so you need to track your patients to figure out who needs what. So essentially, when you start, you will screen with your primary risk stratifier of HPV testing. If it's negative, you can reassure the woman that her risk of developing precancer or cancer is extremely low, and she does not need to have any further management at this time or possibly ever in her lifetime, depending on how often you are going back to screen this population. If the HPV test is positive, then you have two additional risk stratifiers, the HPV genotype and the AVE result. And if the risk is lower in those green boxes, for example, you will not probably want to treat them. And you may bring them back the next year for surveillance if you have that option. But even if you don't, the risks were somewhere between 0 and 1%, so extraordinarily low, and those patients are extremely unlikely to develop cancer in their lifetimes. On the other hand, if the risk is higher, if you're in those red boxes, you will want to perform some sort of treatment like a thermal ablation if possible, or refer for advanced care if you diagnose a difficult to treat high-grade lesion or see a cancer. So putting it all together, the PAVE strategy uses a sensitive self-sampled HPV test to maximize precancer detection. The use of both genotyping and AVE minimizes overtreatment, saves resources, and focuses follow-up on those at the highest cancer risk. And so we have basically proven with the preliminary data that we've presented today that the science works. We know that HPV testing works. We know that HPV testing works with the self-sample. We know that HPV genotyping works to identify women at risk of high-grade precancer. We have shown this both in this study and also worldwide for multiple years. And we have also been able to show the benefits of the AI-assisted visual evaluation of the cervix in addition to the HPV genotyping, which is something that is unique to PAVE. The different sites had different ways that they approached the PAVE strategy. They went to factories, they went door to door. Federica presented some of that in her, Dr. Interisi presented some of that in her presentation. And I just wanted to focus here with one slide on a single day screen triage treat program in the Amazon. The Brazilian team brought the HPV tests, the portable device on which to run the tests. So it is somewhat portable. They brought portable LEAP machines and everything else they needed on a plane to a boat up the Amazon, set up in a clinic, and over a week or 5 days, they screened nearly 1,000 women. They ran their HPV test in the morning in about 2 hours. They found 186 women testing HPV positive. Among those, 33% qualified for thermal ablation, 21 had leaps, and 4 were suspicious for invasive cancer and referred on for additional treatment. And so the next steps that we're currently working on are validating the AVE running in the field, obtaining regulatory approval for these new technologies, finishing the cost effectiveness evaluation, and engaging implementers in trying to bring this strategy to more women worldwide. Thank you very much for being here and for everything you do to prevent cervical cancer.
Thank you, Dr. Perkins. That Amazon story was just so amazing. From an implementer's point of view, that's really amazing, but it would be interesting to see how this moves from study mode to implementation, right, into the field, like you're saying. That would be a very interesting information to get. How do we scale it up and move it into the field for population-based screening? Thank you. Thank you, Dr. Perkins. And the last presenter now, Dr. Nicole Campos, who's evaluating the cost effectiveness of HPV testing with genotyping and AI-based visual evaluation tests. She will be talking on that. Dr. Campos is a senior research scientist at Harvard T.H. Chan School of Public Health. Her research is at the intersection of health decision science, epidemiology, and implementation research with a focus on evaluating the cost effectiveness of cervical cancer screening. As the chair of the cost effectiveness working group within the PAVE consortium, she has led the development of a health decision model of HPV type specific natural history for the economic evaluation of novel screening approaches in resource limited settings. Over to you, Dr. Campos.
Thank you so much. I'll be talking about how we are going about evaluating the cost effectiveness of HPV testing with genotyping and AI-based evaluation tests. In resource-limited settings, selecting a cervical cancer screening and management strategy will depend on the cost effectiveness or value, as well as the affordability, that is the financial impact on a payer's budget. And so today, using the example of Brazil, I'll present the framework that we're using to analyze cost effectiveness of screening campaigns involving the PAVE strategy. So just a quick word to summarize this framework. We've developed a health decision model of HPV type-specific natural history and gone about adapting that model to reflect HPV prevalence in a given setting. In the example I'll use today, it's Brazil. We work with policymakers and stakeholders to identify screening and management strategies of interest, and we program these into our natural history model. And we measure the costs associated with each strategy, and then we use the model with health delivery variables in there as well to simulate the total expected costs and effects of screening and management strategies in a hypothetical cohort of women in our target population. So a quick word on this health decision model. This is a schematic of the HPV natural history model. It's distinct from other health decision models of HPV because we focus on the essential stages on the causal pathway from infection to cancer and the observable and measurable transitions between these. We focus as much as possible on direct estimation of transition risks in order to avoid model calibration to the extent that we can. The model health states on the causal pathway to cervical cancer include no HPV infection with one or more oncogenic high-risk HPV types, with the 8 highest risk types modeled individually and the lesser oncogenic types from the HPV 39 group pooled, precancer, cervical cancer, and cervical cancer death. The transitions between these health states are indicated by the arrows and include the appearance or disappearance of an HPV infection, progression or regression from precancer, and invasion to cervical cancer. We hypothesize that several distinct natural history models may be warranted, as evidenced by several distinct HPV prevalence curves among mid-adult women aged 30 to 49 years. First, a lower HPV prevalence model for immunocompetent populations, such as those in the Americas and Europe, with HPV prevalence that generally declines with age. Second, a higher HPV prevalence model for populations with a lesser decline in HPV prevalence as women age, as is observed in some sub-Saharan African populations, even without a high burden of HIV. And whether this is attributable to environmental conditions that may compromise the host immune response or different HPV variants, we don't know. And then there's also an HIV model that represents women living with HIV who experience very high HPV prevalence across all ages due to a lack of immune control. And despite the very high HPV prevalence, even at older ages in some sub-Saharan African settings, we don't see as high rates of precancer and cancer as we might expect in the absence of HIV. And this could be partially due to underdetection and also possible that the risk of progression conditional on having a high-risk HPV infection may not be quite as high, perhaps due to particular HPV variants. And this would have implications for the effectiveness and the cost effectiveness of screening and management, because in a lower HPV prevalence setting, an HPV screen and treat program might be very cost effective. But in these higher HPV prevalence settings, we would really need to rely on effective triage to avoid overtreatment and high costs and the substantial burden on the healthcare system of treating all HPV positive women. So to date, we've developed a model that represents natural history in lower HPV prevalence settings, and I'll describe this example model from Brazil. We're in the process of developing a model for these higher HPV prevalence settings because that's really critical. That's where a lot of the highest burden of cervical cancer is. These are our data sources for estimating the early natural history transition risks in the model, which are the same across lower HPV prevalence settings, except for HPV appearance. HPV appearance rates vary by population depending on sexual behavior and the prevalence of various types circulating within a population. So we need to adapt the model for each population that we want to analyze. Using empirical data from Brazil on HPV type prevalence data from more than 16,000 women attending public health clinics in Sao Paulo, we mathematically derived estimates of age and type specific HPV appearance in Brazil. And these graphs show our model fit to the empirical prevalence data, with the black lines representing the actual empirical data from the clinics and the blue lines representing our model projected prevalence for each of the HPV types. And as you can see, the model fits the data very well. To inform the cost effectiveness analysis for a particular setting, as I said, we work with stakeholders to identify screening and management strategies that are of interest and that might be feasible to deliver in the field. And we then program these over our natural history model. And Brazil is in the process of transitioning to HPV-based screening, and their guidelines are currently under development. For our initial cost effectiveness analysis of the PAVE strategies in Brazil, we wanted to focus on informing the set of guidelines that are being developed specifically for underscreened women in remote areas or special populations. And so you can see this map of mortality hotspots. There are really vast disparities in cervical cancer mortality, and these red areas are where we wanted to focus our attention first. Our collaborators from the Marco project in Brazil have demonstrated that the PAVE strategy can be delivered, as Rebecca mentioned, in these intensive 1 to 2 week campaigns in remote populations where women can be screened, triaged, and treated in a single day. So when we think about strategies specifically for these remote populations, the status quo is generally that they are not being screened, as the cytology infrastructure that has traditionally been the guidelines is not available in these places. So while new guidelines for HPV-based screening in Brazil rely on colposcopy or cytology triage for HPV positive women, that won't be feasible in these remote populations. We can consider an HPV screen and treat approach where HPV positive women who are eligible based on visual assessment for treatment receive ablation, otherwise might be referred to on-site leave. Some of the HPV tests currently being considered in Brazil offer restricted genotyping, either for 16 and 18 or 16, 18, and 45. But in remote populations without colposcopy and histopathology, these highest risk genotypes might be referred to LEAP. Otherwise, other high-risk types might get ablation. But an issue with this strategy is that these restricted genotyping tests that are currently approved require processing in a specialized centralized laboratory, which would require shipment of samples over long distances, leading to high costs and probably pretty high loss to follow-up due to long intervals before women get the results back. So probably not feasible for these remote populations. Based on these Marco Project campaigns in Amazonas and Para states, we know that the single-day screen triage treat is feasible, and they use a mobile laboratory. So we will be looking at extended genotyping with the 3 risk channels that we've described, along with the AI-based visual assessment with 3 possible risk strata. And we can look at the cost effectiveness of different management options depending on the combined HPV genotype and AVE result, like the concentration curve that Dr. Egeman showed. And this is where the health decision model is especially useful. We can project the effects of management strategies that may not have been applied in practice yet because we know the cost and we know the underlying natural history. So this is a potential list of strategies that we'll look at for remote regions in Brazil with screening and treatment that are feasible through these mobile campaigns. The next step after we've identified all strategies is to measure the cost associated with each procedure involved in a strategy. And we do that using a micro-costing approach where we measure and aggregate all of the resource ingredients used to provide a service at the patient level, including clinical and laboratory supplies, equipment, personnel time, and we also want to account for women's time and transportation costs. And finally, we use the model to simulate the expected costs and effects of screening and management in a hypothetical cohort of women in our target population. The model inputs include these costs that we've estimated for each procedure involved, the cost of cancer treatment, the effectiveness inputs that go in involve test performance, screening uptake, and adherence to recommended management. And our model outcomes, once we run the model, include the average lifetime costs per woman, the total cost for the whole cohort, and the effects can include the precancers detected and treated, reductions in lifetime cervical cancer risk and mortality associated with each strategy, and life expectancy gains. And we use these to compute incremental cost effectiveness ratios in the form of cost per precancer treated or cost per year of life saved. So in conclusion, Brazil will be the first cost effectiveness analysis of the PAVE strategy. We'll primarily consider these screening outreach campaigns focused on high-risk underscreened women. And we also plan to evaluate affordability through a budget impact analysis on the cost of rolling out these screening campaigns in select areas. And we're hopeful that these analyses will help inform screening guidelines for women in Brazil and also provide evidence and a framework for other countries considering the PAVE strategy. So thank you so much for your attention. I just want to gratefully acknowledge my colleagues.
Thank you, Dr. Campos. Thank you. And thank you to all the presenters. This has been an amazing session. The presentations were very informative, and I'm now pleased to invite question and answers if there are any left. The presenters have been doing a great job of answering questions. By the time I get to that question and answer session, the questions have been answered. So that's great work. But we still have one, and I'm going to read that out. And anybody, if you would want to take that. In a developing country like India, where insurance coverage is very low, I believe that AI assessment of cervical cancer occurrence in near future may raise alarm in the underprivileged section of the population. Do you think the AI-based screening in such countries is a bit premature? If so, how can we develop infrastructure and awareness in such countries for AI readiness? I think that's a good question to take live.
Yeah, if you want, I can just say my
opinion. Of course. Please.
I think any intervention we do in the population needs to be explained. And we need to target population leaders in the population that help us to simplify the messages and that they can see the value of that given intervention. I think AI we are all using Google Maps. We are all now embedded into the AI world. And if we make it as a development of technology and not as a alarming tool, we say always we do AI for the benefit of the people. If this AI is at the service of the women's health and we are able to share this concept, women will accept it. What we cannot go is and do things that they are, wow, we bring here a vaccine, or we bring here a test and a machine, and don't explain anything. So that is my opinion. I don't know if my colleagues have.
I would like to add that so this AI technology is an assistive technology. So the final decision will be still at the clinician side. So we are providing this AI tool as an assistive technology that will, and in the second phase of our study, we will be testing whether this assistive technology will improve the clinician's judgment during their screening.
Yeah, that's very important also.
Yes, that makes a lot of sense.
And sort of adding on to that, right now we showed you have the HPV that does one level of risk stratification, and when you add in the AVE, it improves it even more. And what we're hoping is when you then add the clinician judgment on top of that, that will improve it even more, because we know that clinicians make mistakes and we know that AVE can make mistakes. And so adding in those 3 levels of the HPV genotype, the AVE, and the clinician, we're hoping should even further improve the accuracy.
That makes perfect sense, and it does seem like something that would help even in low resource settings, and I hope that answers your question. There were a whole lot of questions that came to us when along with the registration, and I'd like to pick up one of those questions. There was, what challenges do you think you will face in order to implement PAVE on a larger scale? And Dr. Perkins, I remember asking you that just when you were finishing your statement, your presentation. What challenges do you think you will face?
There are many challenges in scaling up anything. I think probably the first challenge is going to be regulatory approval of the ScreenFire test, because it is a lower cost test than the other tests that are out there. And that one of the biggest hurdles to adopting HPV testing and HPV self-collection is that the setup costs are high. And so people are like, well, we can only do VIA because, vinegar is really cheap and we have a flashlight and we have a speculum and that's all we have. So overcoming the cost barrier to implementing HPV self-collection, I think, will probably be the first most important hurdle, because really, the study was done in India, which showed that, they screened 100,000 women with HPV testing and found a 50% reduction in invasive cervical cancer within the next 5 years. And they screened with VIA and they screened with cytology and didn't see it. So we've already done the randomized control trial. It's really just a matter of, the first step is overcoming the challenges to implementing the HPV testing. And then beyond that, the infrastructure that you need for VIA and the infrastructure you need for AVE are the same, with the exception of the colposcope ablation device. So I feel like in some ways that's almost less of a lift than getting everybody onto the HPV self-collection as the first screening test. But I would love to defer to my colleagues to also answer this question.
Something else I would like to add that we have tackled this topic from a research point of view, and this question really relates to implementation. And we couldn't do we couldn't have done what we have done without all the people in the different countries, and there is where the different teams and the organization that it's locally present. So those are the ones that will be the key players for any large scale implementation. So depending on the setting, depending on how the scale up is organized, implementers will need to be extremely involved for that to happen. And that's a whole other story, which involves a lot of the aspects that we are briefly touching upon, but we are not yet at implementation science research.
Right. When we get there, there will be a lot more. Yes, Dr. Desai.
There's an issue that we are seeing every day now, that we are in a country, imagine India, with millions of women. And the government cannot take a decision for one region, has to try to take a decision for the whole
Everyone.
movement. So if that requires, like, let's say, put a price, no, that it's in the WHO guidelines, that a screening test altogether would imply $18. It's okay, an arbitrary number, no? But if you multiply this for everybody, it is a huge amount of money. So that if it's taken as such, and without seeing the work of Nicole Campos, that she will really show the impact in the long run, then you say, I cannot afford that. So I can only do some research questions here and there, and then I will be treating women that they have symptoms, because that I cannot avoid. I cannot say a woman feeling sick, go home. But I can say a woman who has nothing, who is asymptomatic, I don't call her. So it is as well important understanding that we are not planning for something that happens today, but that happens in the cohort of women that have not had access to the vaccines, and that they will keep on dying slowly, some of them, due to cervical cancer, which is a preventable disease. So I think it's as well a political decision of understanding the long run impact. Because only with these policies, like I educate a child, not for today answering me, which is the capital of Spain, but for that small person to have abilities when it's an adult person to be responsible in the society where that person lives. So it is the projection in the future that the policymakers need to take into account in order to take the decision today to invest on something that is more costly than BIA. No?
Yeah. We should create a policy paper along with all these research papers that we can hand to them. I don't know how many policymakers go and look at research papers. But yes, so there is a financial, there's an infrastructure, there is a manpower, there are multiple things that can come in the way when we're looking at implementing it to scale. And I think they're all relevant points. Okay, now we suddenly have all of these questions. Can we do this? Okay. Like somebody's wanting to chat with you, Dr. Inturisi, you can do that. There's another question. I think Dr. Perkins is answering that.
I can try to answer it faster than I can type, maybe. So I think this is do you want to read it out? Sorry.
So for the others, do you want me to read it out very quickly? For AI, threats are numerous beyond their performance and usefulness to any public issue, including but not limited to data privacy, intelligence gathering, ownership of AI models, and associated price dominance, potential for replacing human intel in the long run. Are we as a scientific community sure we have enough knowledge and experience of these risks before we ask the world to move to AI-based diagnostics? Now that is really interesting.
I can address some of the topics. Like there are multiple things to be mentioned here. So I was actually trying to type my answer. So our AI, our AI algorithm is publicly available. Anyone can get access through GitHub. It's an open source algorithm. So what we develop is like we provide this to the whole world. And so data privacy, data like intelligence gathering, this is important issue, but like the device that we're using in our study, it doesn't need to upload these images to somewhere. So each country can keep their own data, and they only use this device to see the result of the AI model. So, and our aim is not to replace humans through AI. Our aim is to improve human judgment, because normally what is available in these regions is VIA. And most of the time, there is no expert clinician to conduct these VIA. And so our aim is to provide a better judgment, a better information that can lead the human judgment to a better results through this AI algorithm.
That, and of course, Dietem answers,
Thank you.
Dr. Eggerman answers everything as perfectly as possible. I did just want to add one caveat, which is that the AI algorithm is open source, but AI right now, one of the biggest limitations is it's not portable from device to device without retraining. So the AI algorithm right now only functions on the dedicated Iris mobile colposcope. You can't just apply it to some other device or cell phone or something and have it work correctly. However, if someone wanted to train a new device, they could use the algorithm, you know, train it with additional images that had a pathology ground truth and then adapt it, but you couldn't just copy and paste it onto a new device without retraining at this time. That's one of the limitations of AI, not just for PAVE, but in general. And failure to do that is one of the major concerns because people have been doing that and then the thing doesn't work. And I think that may be one of the concerns of the person asking the question as well.
Yeah, just
Interesting. Yes.
push on that point a little bit more. From the work that we've done, as we train our models, it appears that the model first learns the device and then learns the disease state. So if you don't get past that first step of having the model learn a new device, it will fail. And again, in the presentation, we showed a little bit about, kind of how much data do you actually need to retrain the device. These runs are about 120 patients, so we're cognizant of not creating a model that only works on one device. We would like for this model to be, applicable to other people. And so that kind of sets a threshold. You probably need somewhere in the order of 120, correctly labeled images to retrain into a new device. But critically, you still would need what we call our seed set, which is the large set of non-Liger images that is our repository for training. And that's also a limitation at this point. We're working on ways and we're evaluating ways to see if there's a potential to retrain a model without having access to that seed set of large training images. And we're hopeful that issue can be resolved as well. But it is currently a limitation.
Okay. I hope that answers your question, though there were a number of sub-questions in that question, but we have seriously run out of time. We are over time. And there are a lot of questions that were asked that we have, and we will look at answering them and sharing them with all of you via mail. Everybody who signed up is going to get a mail. If you have any further questions for any of the panelists or related to any of these topics, please feel free to send us a mail, write into us, and we will be happy to have them answered by the panelists. If you found today's dialogue useful, please follow CCAE on LinkedIn or join the CCAE email list by emailing ccae@cancer.org to get updates on future dialogues. We will be sure to share future publications from PAVE also on these channels, because like they were saying that there's still data that's going to come out, and this was the pilot study. There's a lot more that's going to come. We'll be happy to share it with you. And as Meenu told you in the beginning, if you are a civil society organization interested in learning more about HPV vaccination, read about an upcoming virtual learning series hosted by CCAE. Applications are due by the end of today, July 15th. Last but not least, please share your feedback through our survey that will open in your browser as we close the session. So please do let us know what you thought about this. And I can't thank the panelists enough. Thank you so, so much for being here and sharing this in such simple language so all of us can understand and we know what's going on. There's just so much happening in the screening space. Thank you so much for this to every one of you. Thank you.
Thank you.
Thank you.
Thanks for having us.